Hello, everybody, and welcome to the Florida Society of Interventional Pain Physicians 2022 meeting. Sorry I can't be there with you personally this year, but it's a privilege to talk about COVID and the opioid epidemic in America. Going through my credentials and disclosures, I have no disclosures here that would interfere with my ability to present this in an unbiased fashion. I'm a professor of clinical surgery and anesthesiology at the University of Illinois College of Medicine and the program director for the pain medicine program at Advocate Illinois Masonic Medical Center. In terms of learning objectives, there are three broad objectives I'd like to discuss with you today during our meeting, and that is to define the current opioid crisis, but also to place it into a historical perspective, because for those who may not know or who are uninitiated, we've had an opioid epidemic in America for more than 150 years, and that will surprise many of you. I want to talk about the impact of the pharmaceutical industry on the evolution of this so-called crisis, future directions of the opioid crisis, and the role of COVID, whatever that may have been or may still be, in perpetuating the opioid epidemic and opioid crisis. So, interestingly, that there have been more than 500,000 deaths from opioid overdoses in the world, actually. So this is CDC.gov statistics. It's not unique to America, although America, of course, comprising about 4.4% of the world's population, consumes about 75% of all the prescription opioids in the entire world. We'll talk about that momentarily. And there were three spikes to the present day opioid overdose deaths in this country. And those include in the 1990s, where the first spike was due to prescription drug administration. And so that's where physicians started to receive a lot of attention in terms of our prescribing habits. We'll talk about that as well. Then in 2010, or about 2 decades later, we saw a spike in heroin-related overdoses. And now for the past 10 years, we've seen synthetic opioids, primarily fentanyl, which is manufactured in China primarily and Mexico. It comes across our borders and is reconstituted and sold to the unsuspecting public, contributing to the vast majority of overdose deaths and the surge in opioid overdose deaths recently in this country. About 136 people die each and every day from an opioid overdose in America, and about a third of those involve prescription opioids. But that's a kind of a statistic which bears some scrutiny, because if you look at in the lay press, for example, Tom Petty, well-known musician, or Prince, well-known artist, they both died of so-called prescription overdoses, but during their autopsies, it was found that they had consumed fentanyl. So this is the conundrum that we fall under when we try to stratify or qualify opioid-related overdose deaths. We are certainly in the midst of seeing people who die who have had prescriptions allegedly for legitimate medical considerations, but they also are buying illicit narcotics on the street, primarily fentanyl. 75% of drug overdose deaths in 2020 involved an opioid. And there were 92,000 such deaths in the country in 2020. In 2021, we reached the century mark. There were more than 100,000 overdose deaths in the United States of America. Incredibly sad statistic. And you can see the nation's escalating overdose epidemic. You can see that we've had a slow and steady and gradual increase throughout time in this country, according to the Center for Disease Control. Now, overdose death rates involving opioids by type over a 20-year period from 1999 to 2020, you can see that drugs like heroin have remained relatively stable and are actually on the decline a little bit. Prescription opioids, pretty steady and are actually on the decline somewhat. But overdose deaths from any opioid are surging largely due to other synthetic opioids. Again, at the forefront of these are fentanyl being manufactured in China and Mexico and shipped across our borders. As I stated, in 2021, we reached a milestone in America, more than 107,000 drug overdose deaths from all types of chemicals, not just opioids, methamphetamines, cocaine, benzodiazepines. But remember that many of these are mixed pictures. Many of these consumption overdose deaths include not just the primary drug, but also synthetic opioids, primarily fentanyl. So fentanyl kills at an alarming rate. It's being mixed with marijuana. School-aged children are overdosing when they buy marijuana on the street that's been laced with fentanyl, and they smoke it and they end up going into respiratory depression. This is a well-known phenomenon, many case reports throughout the country. If you look at this graphic, this is drug overdose deaths by state in the United States in 2020. And blue shows increase. 40 states have seen an increase in the period from about 20,000 for 2000 to 2020. We've seen an increase in almost every state, except in some of the northern regions like the Dakotas, Wyoming, Montana, et cetera. But by and large, the vast majority of mainland America, we've seen an increase. If we look at the next graphic, this is a graphic going back 5 years showing the changes in drug overdose death rates involving prescription opioids. And my state of Illinois is highlighted because it was the only state where there was a drastic increase in prescription opioid related overdose deaths. Now, if you go to 2020 or more recently, you'll see that there are now about 20 states that have seen an increase, including, again, my state of Illinois. And Florida remains at a level, which is interesting because of the educational process and the governmental restrictions that have been strongly influential in the state of Florida. More on that later. If you look at drug overdose death rates involving synthetic opioids going back 5 years, again, Illinois and California and Virginia were at the forefront of a rapidly ascending increase in synthetic drug-related opioid overdose deaths. Now, more recently, in 2020, you'll see that 40 states have seen a drastic increase in synthetic overdose-related opioid deaths. So this is a phenomenon like a cancer, which has metastasized and is spreading rapidly throughout the entire United States, except again for the Dakotas, Montana, Wyoming, Idaho, for example. But the majority of mainland America is seeing a drastic surge in synthetic opioid-related overdose deaths. If you look at how the opioid dispensing has changed from 2006, there were a lot of states back then, 6-7 years ago, where there was prescriptions of more than 100 or 80 to 100 prescription dispensing rates per 100 people in the states. But now, more recently, with educational programs and incentives or disincentives for prescribing, in 2020, you can see that now that's limited to certain states like Tennessee, Kentucky, Louisiana, for example, Mississippi. We've seen that this is now limited to the Deep South. So we've seen an improvement, a reduction in the prescribing rates of opioids across the United States of America. Let's go through some historical vignettes because I think it's important to put into perspective the opioid epidemic. Most of you don't know this, but the opioid epidemic in America has its origins in the American Civil War. Before that, there was Frederick Turner, a 21-year-old pharmacy assistant in Austria who was able to isolate not opium, as the slide suggests, but morphine from opium at the age of 21. And Sir Turner was a fascinating individual who really was tinkering around in the basement of the pharmacy in Austria and said, I'd like to be able to find some crystals. And he was the first person ever to isolate from a plant, a naturally occurring substance, an actual alkaloid. And so alkaloid pharmacology owes its inception to Frederick Turner. Before that, we had laudanum, we had opium in its purest sense, and it came in liquid form. So if you had dysentery or a toothache or the baby was crying, you had to apply a little bit of laudanum to that person to get them to stop or to improve their situation related to their underlying condition. Laudanum was readily available without a prescription. Then along came Sir Turner. He was 21 years old. Regrettably, he became addicted to morphine and died at a very young age, below the age of 50, due to his morphine addiction. But he was a fascinating individual in science and is probably the grandfather of modern contemporary opioid pharmacology. Then Alexander Wood, a Scottish physician in 1853, developed the first hollow syringe and needle. And he did so by observing bees, bumblebees who stung. And he said, I think that if I could devise a methodology to administer morphine, because remember, morphine only came in liquid form and could only be swallowed orally. And Alexander Wood said, let me develop something here where we can administer morphine locally at the site of pain. Of course, we now know, and we knew even back then, that you didn't have to administer the morphine locally. You could give it systemically. But at least Wood's contribution remains to date one of the greatest inventions. But if you look at the date, 1853, it corresponds to the inception of the American Civil War, 1861 to 1865. And in point of fact, we had over 400,000 American soldiers addicted to morphine. In fact, morphine use was considered to be soldier's disease. The Civil War by far was the deadliest war in the entire history of the United States, with more than 620,000 deaths, which is about the same total of all other wars combined in terms of mortality. And the number one cause of death was infection, but addiction affected about 400,000 soldiers. Now, how do we know that? We didn't have mass media, we didn't have cell phones, we didn't have television, we didn't have radio. It took a week to produce a single one-page newspaper. So these statistics are subject of great variability and some controversy, but we know that there were hundreds of thousands of young people leaving the war with PTSD, CRPS, which was described at that time, and who developed an addiction to morphine. Morphine was called soldier's disease. And this was made possible and feasible by the development of the hollow needle and syringe by Alexander Wood, a Scottish physician who did his work in England and made it readily available without a prescription for young individuals to obtain morphine and inject morphine and go on to a lifelong addiction. Along came C.R. Alderwright, a brilliant chemist and physician from England, who then looked at this phenomenon from across the pond of all these young soldiers becoming addicted and said, what can I do to use the great analgesic properties of morphine but minimize addiction? And in his genius, he tried to create a new chemical compound called diacetyl morphine by boiling morphine with acetic aldehyde. And what he did was he actually created heroin. So he didn't realize the addictive properties immediately of heroin. He still was relying upon the analgesic properties. We know heroin is an analgesic, but in his haste to create this product, he created a much more deadly compound. In fact, a well-known manufacturer of aspirin in this country and worldwide from Germany, actually for a 15-year period made millions and millions of dollars, not by selling aspirin, but by selling heroin hydrochloride over the counter as pills and tablets. And it wasn't until about 1913, realizing the severity of the addiction properties of heroin, that they ceased the production of heroin. But for the vast majority of this 15-year period, they made their great fortune by selling heroin. And of course, we know throughout history that there have been great individuals addicted to these chemical properties. William Stewart Halsted, who created the Johns Hopkins University Medical School, the father of modern American surgery, for example, he was notoriously addicted to cocaine, and he sought out the services of Sigmund Freud in Austria. He actually didn't meet with Freud, but with several of Freud's minions. And they said, hey, we have a remedy here to get you unaddicted to cocaine. It's called the use of morphine. We now recognize that as switching addiction. So Halsted was addicted variably to cocaine and then morphine, and ended his life again prematurely, again back to his cocaine addiction. The first pain clinic in the United States started in the 1930s by the great John J. Bonica from the island of Filicudi off the coast of Sicily. Good friend of mine, I met him in the early part of my career, had dinner with him, spent many hours discussing topics related to pain. And Bonica created the first pain clinic in America. Again, the emphasis was on interventional pain management, not upon the use of opioids, although obviously Bonica recognized the salubrious benefits to the use of opioids in practice. Now let's talk about the earlier history that led to this crisis. So the first drug laws in America were created in the great state of California, in San Francisco. And this occurred in about 1875, when, after the gold rush of 1849, you've heard of the San Francisco 49ers football team, of course, and the Transcontinental Railroad of 1869. Well, after the railroad was completed and the gold rush was over, essentially, the Chinese influx of immigrants continued, and they created opium dens. And so this was a nuisance to the great people of San Francisco, and they wanted to eradicate these slums. Because remember, in 1875 in San Francisco, the city was filled with prostitution, gambling, narcotics. There were human feces littering the streets of San Francisco in 1875. Exactly the same as we see today, for those of you who have been to San Francisco recently, not to disparage the great city. And so the great forefathers of San Francisco decided to create laws against the use of opium. Then there was the fact that in 1906, the Sears Roebuck catalog was offering for sale syringes, hypodermic needle syringes. You could buy cocaine, you could buy laudanum directly from Sears Roebuck without a prescription. It wasn't until 1914 when Francis Burton Harrison created the Harrison Act to regulate and tax drugs like cocaine and opium and morphine that things began to change in the United States of America. But the opioid addiction and the opioid epidemic continued en masse, full-fledged. Here's from the Sears Roebuck catalog. You see that syringes were available, and they were reusable, of course, for about $2.50. You could buy laudanum for 25 cents, a 2-week supply. And this was readily available without input or prescription by a physician. Here's Burton Harrison, a fascinating figure in American politics, married 5 times, divorced 5 times, or actually one of his wives died in a motor vehicle accident. And he created the Harrison Act, which was really a taxation, just as now we see states leaning towards the taxation of things like marijuana and marijuana-related products. An interesting little phenomenon or tidbit is that Burton Harrison died on November 21st, 1957, the very day I was born, and he died at the very same hospital where I was born, although I never met him. Our paths never crossed, so I didn't know Burton Harrison. But that's just an interesting little tidbit. Then we see 2 articles which were published in peer-reviewed journals, which really changed the opioid epidemic for the worse. And they changed for the worse in 1980 and 1986 because the pharmaceutical industry jumped on these papers and said, hey, look, we've got peer-reviewed literature, one in the New England Journal of Medicine by Jane Porter and Herschel Jick, and the other in the journal Pain by Russell Portnoy and Kathleen Foley, and we'll talk about that. And this was to legitimize, apparently, the use of opioids. So the letter to the editor by Jane Porter, Herschel Jick, looked at about 40,000 hospitalized patients. They found only 4 cases of addiction that could be linked to the use of opioids. And so their conclusion was the development of addiction is rare in medical patients with no history of addiction. Russell Portnoy, who was singularly responsible in many ways for the perpetuation of the opioid epidemic, although he would consider that to be a slight on his reputation, and he was actually responsible for shutting down the American Pain Society because he testified in 2019 that the American Pain Society was in collusion with the pharmaceutical industry. But Portnoy's brief report of 38 patients, along with Kathleen Foley, basically found that in intractable non-malignant pain, the use of opioids is safe. So you can imagine the pharmaceutical industry loved these papers and took this information and went to physicians' offices and said, look, we've got peer-reviewed literature. We've got this article in 40,000 hospitalized patients. We've got this case report of 38 patients without addiction. It's safe to use narcotics for chronic non-malignant pain. It came as no surprise, according to the Wall Street Journal, that Portnoy had disclosed relationships with more than a dozen companies that produced opioid painkillers. Of course, he denounced that this would be influential in his lectures, publications, or his dealings with promoting and proposing the beneficial effects of opioids. Let's talk about the present now. And so in 2007, 15 years ago, 3 large pharma executives from Purdue Pharma were indicted. And what Purdue Pharma did was pay about $634 million without necessarily admitting any wrongdoing. Because Purdue Pharma was misbranding the use of their medication based again on that literature and going from office to office, primary care to primary care, psychology to psychology, pain management to pain management, saying you must be using opioids. Opioids are safe and don't cause addiction. The Sackler family, the owner of Purdue Pharma, has recently agreed to pay $6 billion to offset the devastating effects and the economic effects of the opioid epidemic. Remember that in 2016, the Center for Disease Control came out with their guidelines for opioid prescribing. That was primarily targeting primary care doctors, family medicine doctors, internal medicine doctors who were prescribing opioids for chronic pain outside of cancer and end-of-life scenarios. Here's Purdue Pharma headquarters in Bristol, Connecticut. OxyContin recently has agreed to pay $6 billion in cash. Now, remember, most of their money is hidden in offshore accounts overseas, and we don't really know whether this debt will ever be paid to society, but they have agreed to pay, at least in principle, $6 billion for this opioid epidemic and their role in the perpetuation and misbranding of OxyContin and oxycodone products. The Joint Commission, interestingly enough, diffuses and refuses to accept any culpability in the opioid epidemic, but they produced a primer, a small guide to the appropriate prescribing of opioids for all clinicians. And it was actually funded by Purdue Pharma. And it said that there's an exaggerated concern about addiction tolerance and the risk of death death related to opioids. This attitude prevails despite the fact that there is no evidence that addiction is a significant issue when persons are giving opioids for pain control. Again, dogma, totally misappropriating and misrepresenting and mislabeling the actual facts as we know them today. In 2012, there are about one opioid prescription written for every person living in the United States of America. In 2015, 3 to 4% of the USA population got a prescription for a long-acting opioid. In 1999 to 2014, we saw 165,000 people dying. And in 2017, we saw that the USA, with 325 million people, or constituting about 4.4% of the world's population of 7.2 billion, actually consumed 75% of all the opioids in the world. And here's the data, ladies and gentlemen. You can see that Americans consume and have consumed, going all the way back to the year 2000, almost every single hydrocodone molecule in the world, and the vast majority of oxycodone as well, constituting about 75% of the consumption of all prescription opioids delivered in the United States. Now, your great state of Florida, where FSIP is being held, is ecstatic right now because CVS and Walgreens have agreed to pay $1.5 billion. You can see this is from the Associated Press, May 5th of 2022. Walgreens and CVS are going to pay the state of Florida over several years $1.5 billion. So the Attorney General is very happy. And it's not just Walgreens and CVS, it's all the other manufacturers of opioids who are felt to be in collusion in perpetuating the opioid epidemic. That includes Teva Pharmaceuticals, who agreed to pay $200 million Allergan, and Teva will also provide Narcan for individuals who are using opioids on a regular basis. And that's because it was found out that Walgreens dispensed about 4.3 billion pills of narcotics from 2006 to 2021 over a 15-year period. So the Fed said, hey, we're going to go after you. Walgreens and CVS said, don't worry, don't come after us. We'll pay $1.5 billion to the state of Florida for our contribution to the opioid epidemic. And also, this includes $484 million in cash. Teva Pharmaceuticals, as I said, will give about $200 million. Allergan will pay $134 million. Teva will also give $84 million worth of nasal spray of opioid antagonism to reverse the effects of impending overdose. Now, I mentioned several times the contributions of fentanyl, which is created in primarily in China and Mexico and delivered across our borders. Here's from the United States DEA. You'll see that the Customs and Border Patrol in 2019 confiscated 650 pounds of fentanyl and methamphetamines crossing the border from Canada and Mexico into the USA. This is a relatively common phenomenon. Arizona's always reporting on these types of busts. And in 2019, James McDonald, who was the Assistant Secretary for Countering Weapons of Mass Destruction, labeled and classified fentanyl as a weapon of mass destruction. And you might scratch your head and say, well, how is fentanyl a weapon of mass destruction? Go back 20 years in Moscow when a group of Chechen rebels took over a theater in Moscow and held 900 theater goers hostage. And the Spetsnaz, the Russian equivalent of the FBI, CIA, and maybe mafia, came to the United States and petitioned Professor Theodore Stanley, good friend of mine. You can see me with Dr. Stanley in the corner of the slide. And the Spetsnaz said to Dr. Stanley, we've got this hostage situation. How do we liberate them? And Stanley said, you're going to put fentanyl in the ventilation system, but you're only going to put a couple of drops of fentanyl. Well, the Russians, being a little bit stubborn, you might say, not an indictment against them, they just didn't understand. They put about 100-fold dose of fentanyl that Dr. Stanley recommended, and they ended up killing a bunch of hostages and a bunch of the rebels as well, because they didn't listen to Dr. Stanley. But certainly fentanyl in the misused by the wrong people can be considered a weapon of mass destruction. Let's not forget that not only has there been an escalation in the use of opioids, but also stimulants, because Americans don't want to pass out from the use of narcotics. They want to be wide awake to enjoy the effects of narcotics. So methamphetamines, other drugs like Ritalin, for example, there's a constant escalation in the prescription writing of these because the addict knows they don't want to be unconscious from their opioids. Let's go back and take a quick look again about some statistics I've already discussed. National drug overdose deaths by gender. about 70,000 overdose deaths in 2017. And notice that there's a constant gradual incline. Overdose deaths, notice that I've highlighted that it's other synthetic narcotics from about the year 2013 onward that is killing Americans exponentially, primarily fentanyl manufactured overseas and brought into this country illegally. 47,600 national drug overdose deaths involving an opioid in 2017. We now know that that's about 75,000 in 2021. You can see that the deaths from prescription writing is actually on the decline. However, as I mentioned with Prince and with Tom Petty, people who mix prescription narcotics with other synthetic narcotics like fentanyl, that's exponentially increasing, and more people are dying from mixing prescription opioids with synthetic narcotics. Heroin's on the decline. Overdose deaths from pure heroin are actually going down after that spike that we saw in the last decade. However, deaths from heroin with other synthetic narcotics is on the escalation, on the incline. And so we can't get people unaddicted. We've got to try to find a methodology to limit their exposure and their access to fentanyl. Cocaine deaths are relatively stable for many decades now, but people who die from cocaine with other narcotics, especially other synthetic narcotics, remains escalating in the last decade or so. Benzodiazepine deaths very flat in the United States, but people who use benzos and mix them, we know this, who mix them with opioids, especially with synthetic opioids, that's massively ascending, and we're seeing a huge public health crisis from benzodiazepine use mixed with other synthetic narcotics. Now, the CDC did something which I rarely see them do. They quietly printed a so-called retraction in 2018. They said that they overestimated the number of doses or overdose deaths from prescription narcotics, but it was all too late. The horse was already out of the barn. The water was already under the bridge. They basically alerted physicians that they were coming after physicians for overprescribing, but then they started to do their calculations from emergency room records and the people like Petty and the people like Prince, who were not just getting prescription narcotics, but who were really dying from synthetic narcotics coming into this country from China and elsewhere. So who's to blame for the present day opioid epidemic? Is it physicians? Not really. Is it the drug manufacturers? Well, yes, partially. Is it lay press? Well, clearly the lay press is implicit and complicit in why individuals in America are predisposed to being overindulged with narcotics and overindulge and trying to seek and beseech of their physicians opioid. We went from avoidance and indiscriminate prescribing. There's a balance somewhere, but we have yet to reach that balance. Remember that Americans at 4.4% of the world's population are consuming 75% of all the prescription narcotics. It's off the charts. Hydrocodone, we consume almost every molecule in the world. Oxycodone also disproportionately an American phenomenon. So let's take a look at the lay press's complicitness in all of this. Well, they talk about the right way and the wrong way to treat pain. You better find a physician who knows the right way to treat your pain. And then we talk about pain in militaristic terms. We talk about conquering pain, beating pain. We declared a war on pain. And if you know anything about Americanism, we declare a war on poverty, it doesn't work. We declare a war on homelessness, it doesn't work. We declare a war on obesity, it doesn't work. And so we declared a war on pain and a war on opioids for that matter. And of course, that's bound to fail. We talk about understanding pain because we want to know what causes individuals to have pain so we can seek out more beneficial methodologies to manage that pain. And now we've become the United States of marijuana because everybody wants marijuana. The kids want it, the adults want it, the administrators want it. Everybody wants to legalize it, tax it like Harrison taxed opioids and cocaine back in 1914. We want money, and we want money from the consumers. And so we have to find ways to legitimize the use of marijuana. And we want to know how we get addicted, don't we? But we don't want to do work to fight addiction. We want a vaccine. We want a cure for addiction so that Americans can go on and use their opioids and use their cocaine and use their methamphetamine indiscriminately, but never take any personal responsibility for doing so. Just give me the vaccine for addiction so I can go on and get my prescription for hydrocodone, hydromorphone, fentanyl, and therefore I will just continue to use until I feel like I've run its course, but don't tell me to stop using. Don't tell me to take any personal responsibility. Don't tell me to go to AA meetings or NA meetings or do any work on my own self-improvement. And then we sensationalize the people in this world who've succumbed to addiction. Rush Limbaugh. We've got Heath Ledger. We've got all kinds of celebrity people, and we sensationalize their struggles with addiction. We made a hero out of Michael Jackson. Vicodin, Dilaudid, Xanax, Zoloft, Demerol, Visceral, Paxil, Prilosec, not to mention, of course, propofol. Horribly addicted, and we sensationalize the deaths of him and Whitney Houston and Prince, and of course, as I already mentioned, Tom Petty and many, many others. And here's Prince 2 days before he died, going on his final pharmacy run in 2016 to pick up 240 oxycodone tablets. Day before he had passed out on his private airplane coming back from a venue, had to have the flight circumvented and taken to an emergency room because he was in a horrible overdose situation, and he just died a few days after this. How does the opioid epidemic been responsive to COVID-19? SARS-CoV-19. That's really an important concept. That's what we're here talking about today. And so we've seen an escalation in deaths. I've already proved that to you with our 2021 data of 107,000 American deaths. We never broke the century mark before, but now in 2021, we're already there. And we saw an escalation of opioid epidemic due to COVID-19. How? Because isolation is one of the hallmarks of addiction. And when we forced people into isolation, social isolation, they turned to their drugs. They had no support systems. Their AA meetings were done online. They did virtual meetings. They had no personalization. They weren't singing Kumbaya and hugging each other at meetings like they did before. And they went back to their drugs. They went back to their alcohol. They went back to the abnormal, dysfunctional behaviors. The coronavirus pandemic was a national relapse trigger, according to the New York Times. Isolation, people were struggling with addictions, made treatment options difficult. We had virtual meetings with our physicians. Instead of individuals showing up for one-on-one meetings and giving urine toxicologies and checking the prescription drug monitoring program, for example, we had people who were receiving their medications electronically because they didn't have to go to the physician's office. Here's a nice paper, Changes in Outpatient Opioid Prescribing During the COVID-19 Pandemic, an interrupted time series analysis. There was an increase in the number of prescriptions, not just the number of prescriptions, but the patients who were receiving long-acting opioids. So physicians didn't want to deal with seeing patients virtually once a month. They were giving 3-month prescriptions for longer acting, higher morphine milligram equivalent doses per each virtual visit. And the patients loved it because they didn't have to show up. They didn't have to give a urine specimen. They didn't have to be monitored. And so it was a big crisis. This is from a recent paper published in 2022 that we saw an increase in opioid prescriptions again early in the COVID-19 pandemic, and then things kind of stabilized and leveled off. When we went back to live meetings again, live interactions with our patients face to face, we did see patients becoming more responsible because physicians were monitoring them somewhat more closely. But for the first 3 quarters of 2020, there was an escalation of opioid prescription writing. And then, of course, when we got back to live interaction with patients, we saw it leveling off. The increases started in April of 2020. And then early in the pandemic, patients were given longer acting opioid prescriptions with higher doses and higher morphine milligram equivalents. That has now stabilized. That became back to baseline in 2021, yet and still opioid related overdoses were ascending and escalating throughout the entire period of 2021. We hope that in 2022, we will see that this will return to some normalcy. During the COVID-19 pandemic, there was an apparent substitution of non-pharmacological therapies as well with opioids. So we did, as physicians, learn that we had to substitute non-narcotics for patients with chronic non-malignant pain. And that was really a defense mechanism that we as physicians undertook to preserve our licenses, preserve our practices, and to be not only continue to be empathetic to our patients, but also to protect our practices. I also want to leave you with the thought that physicians have been casualties of the opioid epidemic. Never forget the tragic story of Dr. Todd Graham from Indiana. Todd Graham was a contemporary of mine, same age, practiced in a similar environment that I do. And in 2017, he had a new patient referred to him with orthopedic conditions, chronic non-malignant pain, benign pain conditions, who came to him seeking oxycodone on the very first visit. And Dr. Graham was a very dutiful physician. He completed a comprehensive evaluation. He did an opioid risk assessment, and he told the patient, listen, I don't feel comfortable giving you narcotics. You'll have to come back after a few more visits. We'll talk about it. Well, the patient's husband became irate and followed Dr. Graham out to the parking lot after work and shot Dr. Graham twice in the head and then killed himself. So physicians, be careful out there. Be careful because patients are crazy. They're also demanding. They also have no boundaries. And when it comes to opioids, protect yourselves. That's all I can say. So what's the future of the opioid epidemic? How do we manage our practices? How do we manage our patients? Identify high-risk patients, use your opioid risk tool, opioid risk assessment, do a comprehensive evaluation, do an appropriate targeted physical examination, and make sure you have the appropriate diagnosis. Stratify risks, patients with a prior history of DUIs, a prior history of family or self misuse of opioids, try to exclude them when possible. Learn to give shorter acting agents and shorter prescriptions if you must accept a legacy patient into your practice. Improvement in functionality must be measured as well as improvement in pain. Educate your patients related to adverse events and only use high dose or long acting opioids for chronic intractable pain. Offer your patients interventional pain like the Florida Society of Interventional Pain Physicians. Offer them neuromodulation, offer them intrathecal drug delivery systems, offer them Vertiflex and minimally invasive lumbar decompression, all the things that we do better than anybody in the world. Monitor for side effects. In conclusion, throughout 2022, drug overdose remains a large and growing consideration. It's a public health crisis. We know that. Prescription opioids were formerly driving this crisis. Now it's illicit fentanyl manufactured primarily in China, coming across our borders in Canada and Mexico, cocaine, heroin, methamphetamines. Now, prescription writing has leveled off and is actually on the decline. That's a good thing. Physicians understand that we cannot be at the forefront of the opioid epidemic. The COVID-19 pandemic saw a surge in overdose deaths due to social isolation, lack of face-to-face interactions. That's coming to a conclusion. Urgent measures are now needed to address the diverse and growing list of drug classes and types which are leading to overdose in our countrymen. Thank you for your time and attention. I wish I was with you down there in Florida. God bless and have a wonderful meeting.